Close your eyes for just a moment and picture this. You walk into your doctor's office feeling perfectly fine, good energy, sleeping well, enjoying your grandkids, maybe even walking a few miles a week. You came in for a routine visit. Nothing was wrong. And yet, 6 weeks later, you are sitting in a surgeon's office trying to understand how things move so fast, not because something was obviously broken, but because a screening test found something, and that something started a chain of events your body was never quite prepared to handle. In my 15 years of practice, I have watched this happen more times than I can count. And every single time, I find myself thinking the same thing. If that patient had just known what questions to ask beforehand, the story might have looked very different. My name is Dr. William. And what I am about to share with you today is exactly what almost no one explains to you in a 1-2 minute office visit. Here's the truth that most physicians genuinely struggle to say out loud in a brief appointment. After the age of 70, some of the most common routine medical screenings in this country can cause more harm than good. Not because medicine is failing, not because your doctor does not care about you, but because the math changes dramatically as we age, and almost nobody is doing that math with you sitting right there in the room. Today, I am going to walk you through 5 specific medical checkups that I would personally reconsider after 70. I will explain exactly why the risk to benefit calculation shifts, what the research actually shows, and at the end, I will give you a set of 5 questions that will completely change the dynamic of your next doctor's appointment. Stay with me through all 5 because number 3 surprises almost everyone the first time they hear it. And number 5 is the one most people have never heard about at all until it is too late. Before we dive in, drop your age in the comments below. I read every single one, and I genuinely want to know who I am talking to today. Now, before I go through each of these screenings, I need to give you a framework. Think of it like putting on a new pair of glasses before you look at the picture. I call it the longevity lens, and without it, nothing I am about to say will fully make sense when you are 50 years old. Early detection screenings work beautifully. Find a problem early, treat it, and you potentially gain 20 or 30 more years of healthy life. The investment pays off. The math is clearly in your favor. But 3 things shift after 70, and they shift significantly. First, many conditions that routine screenings find in older adults would never actually harm you. They grow so slowly, cause no symptoms, and statistically, you would outlive them entirely. But once something appears on a report, modern medicine does not have a button that says watch and wait. It has a button that says treat. Second, the body's tolerance for intervention declines with age. A procedure that a 5-year-old recovers from in 2 weeks can mean months of recovery for a 7-8-year-old, with a very real risk of complications, lost independence, or worse. Third, and this is the one I want you to remember, there is what physicians call the cascade effect. One test finds a small abnormality that leads to a follow-up scan. The scan recommends a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And suddenly, a person who walked in feeling completely healthy is living a medical nightmare that began with a test they may never have needed at all. That is the longevity lens. Keep it in mind as we go through each one. Screening number 1, routine colonoscopy after age 75. Let me tell you about someone I will call Margaret, 6 years old, a retired school teacher from Knoxville, Tennessee. Margaret had undergone 2 colonoscopies in her 50s and early 60s, both completely normal. No polyps, no family history of colon cancer, no symptoms of any kind. But a new primary care physician reviewed her chart and suggested it was time for another one. Margaret was not thrilled about the idea, but she did not want to seem like a difficult patient. She went ahead with the preparation the night before, the liquid-based bowel cleanse designed to clear the digestive tract entirely. By the following morning, she was dizzy, confused, and could barely stand. Her daughter rushed her to the emergency room before the procedure even began. She was severely dehydrated, and her electrolytes, the salts that keep your heart and muscles firing properly, had dropped to dangerous levels. Margaret spent 4 days in the hospital. She never had the colonoscopy. And based on her history and risk profile, the evidence suggests she did not need one. Here is what the science says. The United States Preventive Services Task Force, the independent body that sets national screening guidelines in this country, explicitly recommends against routine colonoscopy for adults over 75 with average risk. Their conclusion, after reviewing the full body of evidence, is that the risks begin to outweigh the benefits for most people in that age group. Think of the colon like a long garden hose. When a physician threads a camera through it, there is physical pressure involved the entire way. The risk of a perforation, meaning a literal tear in the colon wall, occurs in roughly 1 out of every 500 procedures. In a younger person, that is a serious but manageable surgical complication. In a 7-year old, it can mean emergency surgery, a colostomy bag, a prolonged hospitalization, and a recovery that fundamentally changes daily life permanently. Meanwhile, the colon cancers most commonly found in older, asymptomatic patients tend to be slow growing. Slow enough that in many cases, they would never cause a problem within that person's remaining lifespan. You would die with it, not from it. What should you do instead? Ask your doctor about stool based tests. These are non invasive, done at home, and can detect the warning signals that would actually warrant a closer look. If you do have symptoms, blood in the stool, unexplained changes in bowel habits, pain, that changes the conversation entirely. Get evaluated promptly, but routine screening colonoscopy after 75 with a clean history and no symptoms is worth a serious, honest conversation with your physician before you schedule anything. Screening number 2, aggressive PSA testing and annual mammography in low risk asymptomatic patients. I want to be precise here because this topic deserves real nuance. I am not saying cancer screening never saves lives. It absolutely does, and it has saved millions. What I am saying is that after 75 aggressive cancer screening in asymptomatic average risk individuals has a serious problem called overdiagnosis. And overdiagnosis leads directly to overtreatment. Here is what overdiagnosis means in plain everyday language. Imagine your body like a neighborhood with dozens of tiny construction projects happening all the time, most of them harmless and slow. Modern imaging is so sensitive that it can now spot those projects from miles away. Tiny, biologically inactive tumors that, left alone, would never spread, never cause symptoms, and never shorten a person's life. You would have died with them, not from them. But the moment the word malignancy appears in a report, the clinical machinery starts moving. Biopsies, specialist referrals, treatment decisions, all of it moves forward regardless of whether that particular cancer represents a real threat to this particular person. Let me tell you about someone I will call Earl, 8 years old, a retired mechanic from Savannah, Georgia, still sharp, still independent, still fishing on the weekends with his son. A routine PSA blood test, which measures a prostate specific protein, came back mildly elevated. A biopsy confirmed a low grade, slow growing prostate cancer. His urologist recommended radiation therapy. Earl trusted the recommendation. Within a year, he was experiencing significant fatigue, urinary complications, and a quality of life that had declined measurably and, in his own words, irreversibly. Stories like Earl's are documented throughout the medical literature. Published findings in the New England Journal of Medicine and studies referenced by both Johns Hopkins and the Mayo Clinic have shown that a meaningful proportion of cancers detected through screening in adults over 70 are clinically insignificant, meaning treatment provided no survival benefit, only side effects. What should you do instead? Have an honest conversation with your doctor about your specific risk profile. If you have a family history, genetic markers, or active symptoms, screening makes strong sense. If you are average risk and asymptomatic, ask this question directly. If we find something, what are the realistic treatment options for someone my age? And is treatment actually likely to improve or extend my life? That single question, in my experience, completely changes the tone and direction of the appointment. Screening number three, routine cardiac stress testing without symptoms. This one surprises people, and I understand why. When your doctor says you are 72, let us just make sure your heart is doing well, it sounds responsible. It sounds caring. You get on a treadmill, or they give you a medication that briefly increases your heart's workload, and they monitor the response. Seems straightforward. Here is what almost no one explains to you in a 1-2 minute office visit. Cardiac stress tests in asymptomatic patients have false positive rates that can reach 40% or higher in certain age groups. Think of a false positive like a smoke alarm that goes off when there is no fire. It is alarming, it triggers a response, but the house is not actually burning. Except in medicine, the response to that alarm is not just opening a window, the response is a cardiac catheterization. A cardiac catheterization involves threading a thin, flexible tube through the blood vessels, usually through the wrist or groin, up into the heart itself. Risks include bleeding, damage to blood vessels, dangerous heart rhythm disturbances, and in rare but documented cases, it can trigger the very heart attack or stroke it was meant to prevent. And here is where it gets even more counterintuitive. If that catheterization finds a partial blockage, which is extremely common in adults over 70 who feel completely fine, many physicians will recommend placing a coronary stent. A stent is a small mesh tube that props the artery open. Sounds like a clear solution, but landmark clinical trials, including the widely cited ischemia trial published in the New England Journal of Medicine, concluded that stent placement in patients with stable coronary artery disease did not reduce heart attacks or extend life compared to medication and lifestyle changes alone. The stent carried real procedural risks and required lifelong blood thinning medication with its own bleeding complications. And the outcomes were statistically no better than simply managing with medication and a daily 30-minute walk. Let me tell you about someone I will call Harold, 73 years old, a retired postal worker from Columbus, Ohio. No chest pain, no shortness of breath, no symptoms whatsoever. His physician ordered a routine stress test. It came back with an abnormal reading. Harold went through catheterization, received a stent, and was placed on blood thinners. 8 months later, he was dealing with a minor internal bleeding episode from the anticoagulants, a hospital stay. And as he put it, more doctor appointments than I have ever had in my entire life. And I felt fine when this all started. What should you do instead? If you do not have chest pain, unexplained shortness of breath, or dizziness during physical activity, talk to your doctor about optimizing your actual risk factors instead of searching for problems. Blood pressure, blood sugar, cholesterol, sleep quality, daily movement. That is where the real gains live. Those conversations cost nothing and carry zero procedural risk. Now, I want to pause here for a moment. We have covered 3 of the 5 screenings, and if you are finding this useful, I want you to drop your age and tell me which of these you have already been through. I read every single comment. I have also put together something for patients who want to go deeper than what a single video can cover. If what I've shared today is resonating with you, the link in the description and the QR code on your screen right now will take you to a resource called the Complete Senior Health Vault. It is a set of 3 comprehensive guides I have written specifically for adults navigating health decisions after 70, covering the medications worth questioning, how to use food as medicine, and a full manual for understanding what your body needs in this chapter of life. Everything we have discussed today is just the beginning of what is inside. We have two more screenings to cover, and the last one is the one I almost never hear discussed, even in medical circles. Stay with me. Screening number 4, routine bone density DEXA scans, followed by automatic medication prescriptions. Osteoporosis is real. Falls are one of the leading causes of serious injury and loss of independence in older adults. I want to be completely clear that I am not questioning the reality of bone loss with age. What I am questioning is the automatic pathway that often follows a DEXA scan result in patients over 75. Picture your bones like a wooden structure inside a house. Over decades, some of the wood naturally becomes thinner and less dense. A DEXA scan can measure that density very accurately. When the scan shows low density, physicians frequently prescribe a class of medications called bisphosphonates. These are drugs like alendronate or risedronate, taken weekly or monthly, sometimes for years. Here is what is often not mentioned in the appointment. Long-term use of bisphosphonates has been associated with a rare but serious condition called atypical femoral fractures. These are spontaneous stress fractures in the femur, the large thigh bone, the very bone these medications were prescribed to protect. There is also an associated risk of osteonecrosis of the jaw, a painful and very difficult to treat deterioration of the jawbone, particularly relevant for patients who need dental procedures. And here is the crucial counterpoint. The single most effective intervention for preventing fractures in older adults, more effective than any medication, is fall prevention. Not a pill, a set of practical habits and environmental adjustments. Research published in JAMA Internal Medicine and confirmed by the CDC shows that Tai Chi practice specifically reduces fall risk by close to 50% in older adults. Removing loose rugs and trip hazards from the home, installing grab bars in the bathroom, reviewing medications that cause dizziness as a side effect, getting regular eye exams, ensuring adequate daily protein intake, and maintaining vitamin D levels through diet and appropriate supplementation. These interventions reduce fracture risk in ways that are measurable, immediate, and carry no side effects. I am not saying medication for bone health is never appropriate. There are patients who clearly benefit. Those who have already experienced fractures, those with very low T-scores, those with specific high-risk factors. But before any long-term medication is prescribed based on a DEXA result alone, the right question to ask is this. Before we talk about medication, can we first review my fall risk factors and discuss what a structured fall prevention program would look like for me? That question changes the conversation from reactive to proactive, and the evidence strongly supports that approach. First, screening number 5, routine carotid artery ultrasound in asymptomatic patients. This is the one almost nobody talks about, and based on what the research shows, it may have some of the least discussed consequences of anything we have covered today. The carotid arteries are the large blood vessels running along each side of your neck that carry blood up to the brain. Think of them like the main supply highway to your most vital organ. The logic behind screening them sounds solid. If we find a significant blockage, we can surgically clear it and reduce your stroke risk. Seems straightforward. The reality is far more complicated, and for asymptomatic patients, far riskier than it appears. Here is the critical number. The surgical procedure used to treat a carotid blockage, called a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during or immediately after the procedure itself. In older adults with additional health conditions, that risk is higher. The United States Preventive Services Task Force explicitly recommends against routine carotid artery screening in adults who have no symptoms, no mini strokes, no episodes of sudden vision loss, no neurological symptoms of any kind. Their analysis found that in asymptomatic individuals, The risk of harm from surgery outweighs the benefit of finding and treating the blockage. Here is why that is the case. A large proportion of adults over 70 have some degree of narrowing in their carotid arteries. That narrowing has often been stable and completely silent for years, causing no problems whatsoever. But once a routine scan finds it, a well meaning surgeon recommends correcting it. And the procedure to correct a blockage that was never causing symptoms can, and sometimes does, dislodge a small fragment of plaque that travels directly to the brain. In my 15 years of practice, I have seen patients come in for what they thought was a simple precautionary check and leave on a completely different trajectory, not because of the blockage that was found, because of what the intervention set in motion. What should you do instead? If you do not have any neurological symptoms, no sudden weakness on one side, no temporary vision loss, no unexplained severe headache, no facial drooping, routine carotid screening is generally not recommended. Your best investment is controlling the actual modifiable risk factors for stroke. Blood pressure is the single largest driver of stroke risk in older adults. Blood sugar management, stopping smoking if applicable, managing atrial fibrillation, and staying physically active are all interventions with a substantial evidence base and no procedural risk. If you do experience any sudden neurological symptom, even briefly, even if it goes away on its own, that changes everything. That is a medical urgency. Call for evaluation immediately. Now, let me give you the practical tool I promised. I call it the 5 question protocol, and I want you to write these down or save them in your phone and bring them to every appointment from this point forward. Question 1. What is the false positive rate of this test in someone my age? This tells you how likely the test is to trigger a chain of follow-up procedures even when nothing is actually wrong. Question 2. If this test finds something, what are the realistic treatment options for someone my age and current health status? This forces the conversation to focus on outcomes, not just findings. Question 3. What is the procedural risk of any treatment we would likely pursue from here? Most people never ask this up front. Every procedure carries risk. You deserve to know what those risks are before you agree to the first test. Question 4. What happens if we monitor this instead of treating it? For many conditions identified in older adults, watchful waiting with regular monitoring is a legitimate, well-supported, and often superior option. Question 5. What is the most effective non-invasive intervention for this condition? Because very often, as we have seen today with bone health, cardiac health, and stroke prevention, lifestyle optimization and appropriate medication outperforms surgical intervention with substantially less risk. Any good physician will welcome these questions. They will respect you more for asking them. And if a doctor ever makes you feel uncomfortable for asking, that is important information about whether that physician is the right fit for you. Never stop a medication on your own based on anything you hear today, including from me. Bring these questions, bring this list, bring your concerns to your doctor. That is how this information becomes useful. Here is how I want to leave you. There is a meaningful difference between medicine that finds things and medicine that helps you live well. After 70, the goal of your healthcare should not be to generate findings. It should be to protect and extend your quality of life, your independence, your energy, and your ability to do what genuinely matters to you. The system is not malicious. Physicians are not trying to harm anyone, but the way medicine is structured, with brief appointments, standardized checklists, and institutional pressure to act on any abnormal result, it does not always leave room for the nuanced conversation that your situation actually deserves. It is not malice. It is economics and inertia. And understanding that gives you the power to advocate for yourself. You have the right to know what a test is looking for. You have the right to know what happens if something is found. You have the right to ask whether a finding would actually be treated and whether that treatment would genuinely improve your life. The best doctors I have ever known understand that sometimes doing less takes more wisdom than doing more. Recommending watchful waiting takes more courage than ordering another scan. In the next video, I am going to talk about something that builds directly on what we covered today, the specific medications that are routinely prescribed to adults over 65 that carry risks most patients have never been told about. The list will genuinely surprise you, and the questions I give you for that conversation may be the most important ones you bring to a doctor's office this year. Until then, drop your age in the comments. Tell me which of these 5 screenings you have already been through and whether any of this changed how you are thinking about your next appointment. Your comment could be exactly what someone else needs to read before they make a decision they cannot undo. This information is educational and intended to support informed conversations with your own physician. It is not a substitute for personalized medical advice. Always make healthcare decisions in partnership with a licensed medical professional who knows your full health history